And yes, you did pronounce it correctly, so appreciate that. Yep, so I'm gonna share my screen with y'all real quick. Alrighty. So yeah, so excuse me, got a little bit of a allergy situation I'm still working on, so I do apologize for any of that goes on during the presentation. But yeah, so this month is about shoulder. So I wanted to specifically pick shoulder multi-directional instability because this is something that I think spans a little bit better across the spectrum from athletic training to physical therapy into surgery, even in some instances. So I thought this would be really relevant for all of us to get to learn and grow in our care a little bit in this realm. So we'll go ahead and get started. I'm gonna close that real quick. Okay. So some of the objectives for this presentation are I want the audience to be able to define and recognize shoulder multi-directional instability, be able to understand the best practice treatments for this as well, and then be able to apply these evidence-based practice treatments and know when to refer out whenever the treatment paradigm that you're working with and the scope of practice that you work with is not what this patient needs. So first, we want to be able to define what is multi-directional instability of the shoulder. So I took this quote from Gaskell et al. Talking about multi-directional instability of the shoulder. And I thought they summarized it really well. They said, when static and dynamic shoulder stabilizers become incompetent due to congenital or acquired means. Now, so I can look at a lot of different things. Obviously, it's a very over-encompassing term, but we'll get into a little bit more of the nitty-gritty on what some specific presentations would look like. But essentially, the biggest summary is just it needs some kind of laxity in the joint and symptoms that occur in more than one direction. Now, when there is not a prerequisite laxity in the situation, then you're dealing with a little bit of more of a traumatic situation typically. And when the symptoms are only in one direction, then same thing. It's usually a traumatic instability. So you're dealing with more surgical interventions or just a very different conservative care, rehab, and strengthening paradigm. But I included this table here, the static and dynamic stabilizers of the glenohumeral joint. Some of the big stabilizers that are static are going to be the glenoid concavity and the version, basically the angle at which the glenohumeral joint sits in the shoulder. It's going to predispose if they're going to have more of contact surface between the glenoid and the humeral head, essentially. The labral height, or I like to think of it as labral thickness, basically enough of just that suction that's going to keep that glenoid and humeral head contact as well. And then the glenohumeral ligaments, so basically the joint capsule and the laxity that could be prevalent in that. And the dynamic stabilizers, or more of the neuromuscular components, are going to be the scapulothoracic musculature, the rotator cuff, of course, and then just the ability to sequence and use these muscle synergies together with the proprioceptive and neuromuscular control involved with that stuff. Okay, so there's three basically systems, I guess you want to call it that, of diagnosing this. I ordered them in order of relevance and the accuracy and reliability for each of these. As with a lot of the conditions that we work with, the subjective history is a big tell. So this is where you're going to find a lot of that that cue in the back of your head that this is kind of leaning and kind of reminding you of multi-directional instability. So we'll get into that first. So these are going to be a lot of the patients that are talking about that they are double jointed. They just have a little bit more mobility than you would think would be average for that kind of patient population. There's going to be a history of previous subluxations or dislocations. Now you might have to tease this out of them and kind of explain it a little bit more, because if you're working with a lot of younger people, they might not know what a dislocation even is if they're really that young, or they might not have a name that they call it. I know a lot of the time that I talk to these people, it's just kind of their party trick that they can actively move their shoulder in and out of socket, which is not always a great thing with these people if that's what they're coming in for. So talking to them about what that is, and then it kind of fits into this bigger picture of what's going on with their body. Like I mentioned earlier, it's typically atraumatic. Like this is just something that kind of has like a insidious onset. They don't really have a clear mechanism of injury, but it is very prevalent for sure. This is also typically more common in overhead athletes and the younger population. Again, like we talked about, they might not have a name for what this is that's going on, but they've always been able to recognize it to some degree. And also just with the overhead athletes, just that the position that they're getting into going to require a lot more dynamic stabilizing control of the shoulder. So if there's any kind of issues with that, it's going to be way more apparent in those situations. And this is where the athletic trainers have a little bit of a advantage over the other ends of the healthcare spectrum. They get to actually see these athletes on a more continual basis and get to see a little bit more of the athletic performance side of things. So a lot of time, if they don't mention it outright, you can kind of observe this as well. There's a decline in strength and athletic performance overall as weeks and months kind of go on. And then also it's going to be more position specific symptom provocation. So again, we talked about those overhead athletes. A lot of the time you'll hear about pitchers and volleyball players, basketball players, even anything above 90 degrees in the coronal or the sagittal plane is going to be a little bit more iffy as far as like how much stability there is in the shoulder, but that's also where they live. That's where a lot of that sport is being done. So they need a little bit more stability for that reason too. So none of these are like an outright gold standard, but all of them together can kind of create a cluster where you're strongly predisposed for this to be what you're working with, is the multi-directional instability. Next, we'll go to the physical exam. So after you get the history and you're kind of leaning towards, I want to test and see if multi-directional instability is what's in play here. Here's some of your go-to. So Sulcus Sign is kind of the top one that I found. It's a lot more common with anything. Nothing is a gold standard in and of itself, like I mentioned before. So just take this in a cluster and kind of in the context of what everything else is saying. But Sulcus Sign, if you don't know what that is, essentially the patient sits kind of comfortable with their shoulder in a relatively relaxed position. The therapist or trainer goes next to the patient, provides a long axis traction, like a distraction force, to the upper arm or the humeral head to come out of the glenoid socket. If there is greater than 2 centimeters difference between the tip of the acromion and the top of the humeral head, that's going to be a positive sign. Now that's relatively subjective. I don't know that anyone can do that and hold a tape measure up at the same time. So use a little bit of clinical reasoning as far as if that looks abnormal, if that looks about 2 centimeters. Again, nothing is in and of itself the gold standard. So just take if it looks like it's an excessive amount, you move on to the next thing and kind of see the context if it fits. The Baton hypermobility scale is going to be a big tell in this as well. And for those of you that may not know what this is, it's basically a scale that generally can classify hypermobility just in a general sense. So it's not specific to a body region, but some of the factors are if you are able to just stand and have hyperextension in the knees, I think it's greater than 10 degrees is technically the rule on that. Elbow hyperextension also same 10 degrees. If you are able to place your palms on the floor in standing, to like bend forward and do that. There's a couple more. I think one of them has to do with being able to touch your thumb to your radius, kind of in a flexion position. And then I believe there's also a component that talks about bringing the pinky past 90 degrees with your hand on the table. But either way, there is a certain context to that as well. Just because they're hypermobile doesn't mean that they are dysfunctional. It just means that you might have a little bit more of a bias towards having this kind of condition. The loaded shift test, now that is something kind of similar to the Sulcus Sign. What you do essentially there is you're providing a long axis traction with the patient in resting comfortable position. And then you provide either an anterior or a posterior force to the humeral head. And again, this is even more subjective, but if there is a greater than 2 centimeter degree difference or deviation of the humeral head out of the glenoid cavity or out of just the general shoulder socket, that'd be a positive sign as well. That's going to be a little bit better if you're looking. Sulcus Sign is more generalized hypermobility to the shoulder. Loaded shift is going to be more specifically biased towards either a posterior or anterior instability. And then as we talked about that overhead position, so manual muscle testing, external rotation at 0 degrees, kind of at neutral, if they're really, really higher tissue sensitivity levels, or ER and IR at 90 degrees, either at abduction or flexion. more specific to what their sport would require, I guess. Things you're looking for are pain provocation, of course, any kind of other symptom provocation, just it feels unstable, feels kind of off, anything that kind of vague terminology like that. And then if they're feeling any kind of subluxation or apprehension, you'll see a lot of the time those people that they can just tell, like that's the position that it feels unstable, and you try to put some kind of force on it, they're going to feel it's going to come out of socket. So you'll feel these kind of guarding, a little bit of wincing. They'll just be able to tell you it feels like it's coming out. Anything like that, that's a positive sign for sure. Some of this you might be able to do on the field or on the court, on the pitch if you play soccer. But a lot of it is more done just at any time, because if they have a hypermobility, this is kind of a general condition. It's not going to have a traumatic onset that needs to be tested at a certain time. So that is the physical exam. Now I included imaging because a lot of the research that I did included that to some degree, but it made sure to state that this is not the gold standard, which is kind of ironic because a lot of conditions it's the opposite way around. The imaging is the gold standard, but there are three main kinds of imaging that could be used for multi-directional instability. And I also kind of ordered these in order from highest commonality to lowest commonality. So X-ray, if you are going to get diagnostic imaging, is going to be one of the ones. So it's going to look for any kind of anatomical abnormalities that might contribute to this glenohumeral instability, whether it has that glenoid version that we talked about, like there's some kind of predisposition that could be going on there. Or if you have any kind of other just like humeral head flattening, like decreased convexity, anything like that, or concavity of the glenoid fossa as well would all contribute to that instability. MRI is a big one too. You're more looking for any kind of soft tissue abnormalities. I kind of mentioned that last, but any kind of compromise with the labrum, whether there's tearing, fraying, any kind of separation that could contribute to instability as well. And then rotator cuff tears. Now this is kind of where you get into for the labrum and the rotator cuff, a chicken or the egg kind of conundrum where you might see that, but it's more a sense, okay, did that cause the instability? Or did they have some kind of instability already going on, and then that excessive movement of the humeral head within the glenoid cavity is causing increased friction and tearing and fraying on the labrum? Now, who's to tell? The big thing is just knowing if you can work from both ends, where you fix the labrum either surgically or conservatively, and also work on the instability of the shoulder that maybe caused that in the first place. Either way, that's why I tell my patients, it doesn't matter which one came first, we're going to work on both, and both need attention anyways. So, and the same for the rotator cuff tear. There could be excessive humeral head movement within that glenoid cavity, so you need a little bit more stability of the rotator cuff, which could cause excessive tearing. Even just like a tendonitis or tendinopathy would be a result sometimes of that too. And then they also mentioned arthroscopy as kind of like an anecdote almost. This is something that is technically within the wheelhouse of these surgeons to have as an option. Now, I this is my own bias, I recognize, but I am never really one to jump to doing arthroscopy for anyone for any condition, just because it seems kind of backwards that they're going to use surgery to see if they need to do surgery. It just is at the discretion of the practitioner, I guess, at that point, technically. So just make sure you're having a good communication with whatever surgeons, orthopedists, whoever is going to be working with these patients in addition to you, whether you're in the athletic training side of things or in the physical therapy side of things. So that is all to define and recognize the shoulder multi-directional instability. Now we're going to go for some of the treatment approaches. Now, one of the things that I loved about this is that it is a lot more common to have a conservative care positive outcome than to jump straight to surgery. So a lot of the research that I found said that about 80% of patients that have this very typical laxity plus one motion hypermobility, the instability and multi-directional, 80% are going to recover better with conservative care like physical therapy or athletic training, just rehab in general. Now, a lot of it said up to about 6 months is required, especially when you're getting back to return to sport. Now, granted, this is not going to be, for all you physical therapists out there, this is not going to be in the clinic a lot of the times, unless they just have amazing insurance and your clinic will allow that kind of thing. But typically what will happen is you'll get them to a certain point where you're kind of out of the woods with a little bit of the earlier side of the rehab, like you're establishing some of the neuromotor control, and then they would get to see a strength conditioning coach, athletic trainer, if that's available to them, just something to carry them from where they're at that point, where they're a little bit more safe, I guess you can say, to start doing some higher level strengthening and sport specific conditioning. But from beginning to end, it technically would be about 6 months. That little sub note that I have under there with the 16% with traumatic onset, now that's kind of referring back to if there is instability of the shoulder, that's a traumatic onset, which is not what we're discussing, but I thought this was kind of relevant and interesting to note. If there's atraumatic multi-directional instability, which is what we're talking about, 80% of the patients recover without surgery. If there's a traumatic onset, only 16% get better with the conservative rehab without surgery. So I thought that was pretty interesting. That's why there's such a stark contrast between if it's atraumatic multi-directional instability versus unidirectional traumatic instability. Very different treatment approaches. Now for that 20% with the multi-directional atraumatic instability that don't get better with the conservative care, with the rehab and strengthening and physical therapy and athletic training, this is when they're a candidate for surgery. Now, I think 6 months is a little bit conservative as far as how long to wait for this, because then you're talking about they're out of sport for 6 months or out of work for 6 months. Then you tackle on any kind of rehab time afterwards. That's a lot of time to be out. So a lot of it is just use your own discretion that if they look like they're not going to be a candidate to benefit from the conservative care after what you would deem with your clinical judgment as an appropriate amount of time, then you need to have that communication with the surgeon or with whatever doctor they're working with, and just have that communication to be on the same page, whether you want to continue with the conservative care or if something else needs to be done. So just got to know our scope and have communication with everyone we're working with. So for that 20% that would benefit from the surgery, I did find there are several different approaches to that, and we'll go through them pretty quickly. This is not our scope of practice, so I don't want to spend too much time on this, but I think it's just good to know the context of the whole spectrum of what could be happening with these patients. So the most common surgery is the glenoid osteotomy. This is essentially where they deepen the glenoid fossa, basically kind of provide more surface contact area for that humeral head to have with the glenoid fossa. Now, obviously, these are for patients that have a little bit less glenoid concavity. You're not going to do this for someone who has a perfectly normal, whatever that is, glenoid cavity. You're going to just feel that that is actually the issue that's underlying. Labral augmentation is another option. This is again for people that have labral issues that are causing some of the instability. So with the labral augmentation, if you don't know what this is, like I didn't know what it is, essentially it's an autograft tendon that they take from elsewhere in the body and they basically stitch it to the labrum that's already there. Excuse me. Essentially thickening the labrum to provide a little bit more suction for that glenoid concavity and the humeral head to work with. The next is the open inferior capsular shift. This is essentially where, if you think of the anatomy of the joint capsule, there's always a lot more loose tissue in the joint capsule on the inferior side. They essentially will go in, remove some of that part of the joint capsule, and then it provides a little bit more tension and also stability of the shoulder within the joint capsule at that point. There is arthroscopic capsular plication, which is a very similar approach as the one I just talked to you about before. But with this one, instead of just focusing on the inferior capsule, they will take, again, loaded shift test. This is where this is relevant. If they have more instability in the anterior capsule or in the posterior capsule, they will specifically approach that part of the capsule, remove a certain section of it, almost like in a triangle, and then they will pull the two together to provide a little bit more tension in that part of the capsule, almost like they're overlapping it if it really needs it as well. And then the last one, thermal capsuloraphy. So with this one, it's essentially like shrink wrapping the capsule to tighten it. So they will apply some kind of direct application of heat to the joint capsule, which will then kind of make it shrink, essentially like shrink wrapping. And then it will tighten the capsule at that point. Now, this used to be a lot more cutting edge. a lot of the recent evidence is kind of suggesting it has higher failure rates than they originally thought there was. So not as highly recommended anymore, but it's still within the wheelhouse of what they could work with. So those are the main, if not all, the surgical interventions that the patient might be undergoing if rehab does not work conservatively. So, sorry, I'll back up a little bit. So in a lot of the research that I did, they would compare different kind of protocols essentially for the conservative care for these patients. Now, it's not just working on certain muscles or certain sequencing, because every patient presents a little bit differently. So they wanted to actually define certain protocols for these patients that would encompass a little bit of everything. So one of the earlier ones I got put out was by Dr. Watson. He basically went through this 6 stages of here's how you approach these patients, here's how you work with them to get better glenohumeral and scapulothoracic motor control and stability. And that was basically matched up versus other protocols that got proposed. And each time when they would compare them side by side, apples to apples, the Watson protocol was typically a little bit more successful with these patients. So that's the one that I chose to work with on the conservative care side of things. So we're going to dive a little bit deeper into the Watson protocol. So essentially the big goal for this, if you want to call it that, is you're trying to check for an effect of correction. So what that means is you're basically finding what their issue is and then basically correcting that and then working with that as your goal for all of the treatment essentially. So what that looks like is the patient will perform some kind of objective test, whether that's manual muscle testing like we talked about before, especially that ER and IR at 90 degrees, flexion abduction, or if it's more just active range of motion. If they know that there is some kind of movement, your concordance sign that provokes their symptoms, that's going to be your objective test, excuse me. Now, what you do at that point is you have them perform that test, use your clinical judgment to know here's some abnormalities that are happening when they perform that movement. Such as if you have a patient that is working at ER and IR 90 degrees and you notice that there is some kind of shift of the humeral head whenever they perform that movement, or if the scapula doesn't look like it's upward rotating, it's more just elevating, then you essentially would correct that externally with your own hands and then have them perform that same objective movement or test. And if there is less symptom provocation, doesn't have to be complete removal, but just less provocation, then that is your positive sign that this is the goal you're trying to accomplish with all your rehab. So it's a little bit of trial and error. I found just knowing exactly what's the most effective. They might have a couple things because it's multi-directional, right? So you might have to find the one that's a little bit more sports specific or one that's a little bit more provocative of their symptoms and kind of work under that premise. And there might be several different things that are really relevant for them. So you have to just kind of balance it out with what are the high priorities and what are low priorities, but addressing all of them appropriately. So like I said, you assist the scapula, stabilize the humeral head during these movements, try to find that symptom relief to some degree, and then work from there. So I'm going to go through the stages now one by one. I included some of the pictures from the actual Watson protocol so we can tease those out a little bit. So stage 1 is basically gaining basic scapular control and coronal plane control at 0 to 30 degrees. So some of the exercises that they recommended would be just that scapular setting where you're pulling that scapular retraction and a little bit of depression if they have a lot of upper trap movement, but then also gearing that with a little bit of external rotation to get the rotator cuff involved. Now, obviously, working both on the rotator cuff and the scapula would be ideal in my opinion, but again, you have to work with what your patient is not really sufficient at. So if they have excellent rotator cuff strength and scapula is not moving properly, then maybe biased more towards that, but doesn't mean you neglect or have to avoid using the rotator cuff, obviously. So that's stage number 1 is getting that. Stage number 2 is more specific posterior musculature development. Now they're talking more about posterior cuff specifically. So a lot of external rotation type exercises, maybe even a little bit of horizontal abduction if you want to get some of the posterior deltoid, but we'll get into that in a minute. But just basic motor control at that point too, getting a little bit of isometrics, some isotonics as well. Obviously you can see they love TheraBand for a lot of their exercises because it's a good proprioceptive feedback device. So just one option for you, but I like that these are more concepts to apply, not specific, do these exercises at these parameters for this long of time. It's a lot of clinical judgment involved, but also giving you a little bit of guidance. So stage number 3, getting into flexion control from 0 to 45 degrees. So earlier we talked about coronal plane. Now we're getting a little bit more sagittal. So again, a little bit of guidance, not strict parameters. So I can tell already from that picture, they're probably a little bit above 45 degrees, but close enough, right? So working on flexion control, a little bit of abduction, adduction resistance, maybe to really stabilize the humeral head, a little bit of ER and IR resistance, maybe added on top of that. But again, a little bit of reactive isometrics involved, as well as just actual isotonics and isometrics by themselves. Stage 4, getting into the sagittal and coronal plane up to about 90 degrees now. So still working in the 2 planes you've worked with, but just progressing a little bit more. And they don't really talk about this, but there is a lot of rotation that's in the pictures, but they just didn't mention it specifically because it kind of goes in those planes as well. So again, this is where you use your clinical judgment. If the scapula is the focus, then maybe gear more towards the exercises that resist that a little bit more difficult. If it's more rotator cuff or glenohumeral focused, then maybe add a little bit more rotator cuff on top of that. So, but these are basically just some general ideas. You can get some TheraBand hooked into a wall or a railing system of some kind, getting a little bit of that retraction, the scapula setting, and then adding on shoulder movement on top of that, just to really get the control there. I know this is the place where a lot of people will use body blade. To me, that seems a little bit premature because a lot of the time I've seen when I do this, they instantly will lose a lot of that scapular control and just start reverting back to what's familiar habits for them, which is what we're trying to break them on. So you can, I have had patients do well in this phase with body blade, but just be really conscious of their mechanics when they're doing this. Don't assume that they can do it properly quite yet. In stage 5, this is the isolated deltoid drills. This is where I talked about a little bit of that posterior deltoid being in play with the posterior musculature. This is where it's way more prevalent. So the 3 pictures, I'm sure y'all could imagine, posterior, middle, and anterior deltoid are more the focuses here. But also you can see they added a lot of scapular control on top of that. So getting that scapular setting, the retraction depression, adding in more deltoid specific movements on top of that. So I love that. I do that a lot of the time with my patients for a lot of things. Stage 6. So this is more the return to sport and return to work or function specific stage. So earlier we had kind of been keeping the range of motion at 90 degrees and below, but now we're trying to go beyond to get to just full function at this point. And it's a lot more task and sport movement specific. So this is typically involve working with ER and IR at 120 degrees. So this is where they talked about, this is not a strict parameter or guide. It's just what they found in the study is that a lot of the time when they were letting the therapist use their clinical judgment on this, they found that they ended up in the 120 degrees plane a lot of the time. I think that that's just where the scapula and the glenohumeral joint get just a little bit at a disadvantage as far as the stability goes with this static stabilizers. There's a lot more demand shifted to the dynamic stabilizers at this point, which is what we're working on. So that might be where you hang out a little bit more and working in that range more than other ranges. This is where knowing your patient's sport or function specifically and breaking down those components of the movements is going to be really helpful as well to make it very relevant and unique to what their demands are. This is also when you can start incorporating some close kinetic chain stuff, which I thought was interesting because a lot of the schooling that I had very generally around proprioceptive neuromuscular control of the shoulder required glenohumeral stability in a close kinetic chain earlier on. So I thought that was interesting that they advised to wait till the final stage to do this. Maybe it's just because the demands are a little bit higher and they wanted to wait till they had better control to start doing that stuff. I don't know, but it is interesting that they found that that's where it's a little bit safer to work at that point. Maybe just to get the basics down before you start tacking on a little bit higher demand stuff. But also this is where a lot of function needs to happen. So close kinetic chain has to happen at some point. So I have to incorporate it somewhere. The picture I love because that is super specific. It's essentially the pull phase of a freestyle stroke for swimming, and they're adding some scapular resistance as well as some upper extremity resistance on top of that with again, the TheraBand for that PNF a little bit, and getting the ball for a little bit of tactile feedback to the scapula as well. I love it. So I talked about how these are all just general guidelines, but there are some parameters that they suggested along with this and that they observed, more common. So exercises should be pain-free, number of repetitions. They found that that typically ended up being 3 sets of 20 with a 2-second hold. When you're talking about stability being the goal of your strengthening, now you might want to have a little bit more time under tension just for the hypertrophy and strengthening side of things. But also I found that that also just creates a little bit more neuromotor control as well. It's a little bit more fast. It's a little bit more just conscious of where they're moving, how they're moving, all that kind of stuff. And also it just gets a little bit more fatigue, which is going to provoke a little bit of symptoms, which then comes back to the pain-free side of things. So we don't want to provoke the instability. We're trying to work just shy of that kind of stuff. So it said pain-free number of reps, but really it meant symptom-free. So if instability is their symptom, then you work where it's not creating any kind of instability and they're feeling safe with what they're doing. They used, as you can remember from the pictures, they used dumbbells and TheraBand. They were using 0 to 5 pounds, yellow to green, sometimes blue TheraBand for their exercises. And the big thing that I haven't mentioned yet. So to progress from one stage to the next, they had 0 timeline guidance on that. The only thing that they talked about was it can happen whenever the patient can achieve the exercise without any kind of cueing via like verbal or tactile cueing, or they don't have any kind of symptom provocation, and excessive fatigue. So if none of those things are happening with the stage that they're in, then they need to jump to the next phase. And the goal is just creating control and strength and then moving on. If you progress to a new phase and it seems like they've really lost all of the control, maybe hang out in the prior stage a little bit longer to really get that down. Kind of the stages of learning we're working with a little bit with this. So again, probably said this a dozen times so far, but using your clinical judgment to know when they're appropriate for the next phase and just using that as a loose guide and kind of transitioning between the phases even. So those are the loose parameters that they talked about. Here are my references. The Watson protocol, the original one, was actually separated into 2 different papers. There's part 1 and part 2. I think they were released almost at the same time, maybe in just different editions of the paper. Yeah, both 2016. So essentially what it is, the part 1 is talking more about the guidelines as far as what they wanted to establish for the protocol and the goals. And then the first 2 stages, the next paper was the remaining 4 stages. So if you wanted to look those up, I'm more than happy to send those in the email. I think we'll include with the post-talk email that Nicola sends out. But yeah, it is a really good paper. It kind of dived a little bit deeper into each of the protocols and each of the stages and what the rationale for each of them are. It had a lot more recommendations as far as certain exercises you could utilize. So if you're looking for a little bit of inspiration, that's a great place to start. So, and then I also used Dr. Millett's paper with just kind of talking about the general management of multi-directional instability. I also took a systematic review to talk about the different protocols kind of competing with each other, which ones were the more successful ones, which is how I came with the Watson protocol. And then this Deadman Clinic is just, if you don't know about it, it's a pretty phenomenal physical therapy clinic in Vail, Colorado. I think they have a couple of different locations, but primarily I think it started in Vail. And then they also have, Deadman Clinic is the orthopedic side of things. Howard Head is the rehab side of things. But either way, a lot of good resources out there for some of the sport-specific populations. You know, they a lot of the time work with Olympic athletes, which is really good for right now. So, and that is all. And I think Nicola was going to go ahead with the discussion questions. I guess we can bring up now if anyone had any questions just about the presentation before we get into the discussion.
That was great. This is Sarah. I'm an athletic trainer with Baylor. I worked full-time with swimmers for quite a few years, so this brought back all the swimmer shoulders days, but that was awesome. Actually on the program committee for SWATA as well, and that was a great talk. So you should consider submitting for SWATA 2022 next year. to share that with our athletic trainers because that was awesome.
Great, I appreciate it.
Yeah, I second that, Michael. It was a great presentation. It has a lot of real applications. I loved how you talked about some applicable signs like the sulcus sign that we can do in clinic, as well as being able to use the Watson protocol. One of the questions that came to mind when you've seen this in clinic, have you noticed that patients tend to be atraumatic bilateral instability, or are they more of a dominant or non-dominant side with that instability?
Yeah, it's a good question. So a lot of the time, these issues are more unilateral because of the unilateral sport nature. So swimmers, I think, is the one exception to that. As Sarah pointed out, it's a really common thing with swimmers to have that instability, just because of the demands that it's put under with how much movement they're working with. But yeah, a lot of the time, if talking about pitchers, volleyball players, basketball players, football players, a lot of it is unilateral demands on the shoulder. So I found just for that nature, it's a lot more of the unilateral side of things. Now, if you were to test the unaffected side, you might find some of those sulcus sign and the load and shift test were positive, but no symptoms. So maybe you want to consider working both sides just for prevention purposes, but they're not typically coming to the clinic for bilateral issues.
Great. The other question that you presented was other treatment techniques or ideas that were not mentioned that have worked well for you. You know, as far as the stages you provided, I have worked with a few multi-directional instability athletes that were dealing with some of the issues and some of the weaknesses. And so we didn't move into some more of the advanced stages, stage 5, stage 6, until we were pretty far into our rehab protocol, just because they were still actively using those during their sport. So a little different than sometimes when we get to see them in the PT clinic, where they're not in sport or they're not actively participating at the same time. How would you progress an athlete that was participating at the same time, but they're still trying to work through that non-surgical approach?
Yeah, so it gets really tricky. Having a good relationship or communication with whatever coaches that the athlete is also working with their sport is super important at this point. So if there are instances where they can perform their sport, let's just say soccer, for instance, not a lot of glenohumeral instability that would be a problem with soccer. So yeah, very, very early on, I think they'd be appropriate to return back to that kind of sport, but just knowing if there are instances where very rarely, like maybe a throw-in, they would be required to do some kind of stuff, or just for training purposes, they're required to do stuff that might require the arm on the ground, like push-ups or just very general exercises that would use the arm, then maybe you want to have more communication to have them avoid those activities that are essentially unnecessary symptom provocation. So now if we're working with someone that's got an overhead athlete sport, then that gets a lot more tricky. And I think just educating the patient a little bit more about what's going on and why that 20% exists where they don't have success with the conservative care, I think would be biased with those kind of patients. But just having them understand, I know a lot of these people, this is more for fun in the high school realm. So just knowing that if you take 6 months off, it's not going to be the end of your world. This is just something you're doing for recreation. If we're working with more professional athletes, it's a whole different discussion. This is their livelihood. This is their job, essentially. So getting them back at the quickest appropriate time is going to take a little bit of trial and error, and just knowing when that symptom provocation, I call it like the buffer of margin of error, is if they have any kind of symptom provocation, does it last for more than 24 hours? Does it cause a dislocation or a subluxation or just apprehension and stability? Those are all very different levels of symptom provocation. So if they are able to perform their sport with minimal threat of symptom provocation, then maybe it's something that you kind of work in conjunction with them, and just being really careful to not overdo the rehab side of things when they're also doing stuff outside of your clinic or training room to cause weakness and other issues that could come up.
Great. Thank you for that. My last question for you, I noticed that you didn't mention any specific taping or bracing strategies. Was there anything mentioned in the literature that could make our athletes a little bit more functional while they're working through this rehab process?
Yeah, so yeah, I thought that was odd too, that they didn't talk anything about taping or any kind of other modalities that could be in conjunction with that. But again, take it for what it's worth. This is just expert opinion. Was at level 7 evidence, so pretty low on the spectrum. But the whole premise of the taping is there's no kind of mechanical difference with these patients. When you apply tape, it's all proprioceptive. So if that is the goal of what our exercises is, to me, it makes total sense that adding a proprioceptive modality on top of proprioceptive exercise is going to work perfectly. So yes, I have used that a lot with these patients. Essentially just doing the typical like deltoid, essentially taping approach. Sometimes scapula to get that retraction depression, to get that feedback a little bit better. Rarely am I going to do anterior, but a lot of it's more posterior cuff focused if you do anything on the sagittal plane side of things. But yeah, taping is great when it's in context with exercise.
Well, thank you so much for that. We really appreciate your time and all your hard work on this. I will go ahead and end the recording now. If you want to switch back over for your screen share.